Okay, thank you. Thank you for the kind introduction and thank you for the inviting me for this talk. So over a period of just 10 minutes, I'm going to discuss about the mesothelioma. I'm a radiologist from Jankara Imaging. So I'll be talking about the diagnosis and response assessment imaging point of view. So as we know, the pleural mass is comprising of a vast variety of entities, but vast majority are there, but still most common are just in terms of malignant lesions, the commonest one being the metastasis and the mesothelioma. And right now we're going to discuss about the mesothelioma, and let's try and understand how to make this diagnosis, how to avoid the misdiagnosis, and how to differentiate from metastasis and other lesions. And then we'll briefly see about the response assessment as well. So mesothelioma, as we know, is the disease of elderly, and asbestos has been proven to have a direct link with asbestos exposure with the mesothelioma. So that history really becomes really important. And we also tend to see the other asbestos-related diseases in the chest when we do a CT scan. So that we are also going to see. And but typically we need a pleural biopsy for confirmation of diagnosis, and especially to rule out metastasis, which is far more common. And at times even histopathology might be difficult, but we, with the advent of different immunohistochemistry and electron microscopy with different markers, now it has become really still feasible to differentiate the two. And in general, overall, the mesothelioma has a poor prognosis because by the time the diagnosis is made, it is relatively in the advanced stage. So imaging again becomes important, especially to differentiate from the benign pleural plaques and diseases that might be present, especially in our country in presence of tuberculosis. So typically the mesothelioma involves the parietal pleura, and fissural involvement is very common, which also really helps, and that I'm going to discuss in the coming slides. And typically it presents with the pleural thickening along with the mass-like thickening along with the pleural effusion. And there is something called as a frozen mediastinum sign that has been described, and I'll show with examples also. And typically the diagnostic tool used at the first time is CT scan. Typically a CT scan has been done, and sometime MRI may be done, typically used as a problem solving tool for particular answer that you need to get, especially whether the patient is operable or not, some specific answer. And that also we are going to see with examples. Perfusion MRI really helps in times of response to chemotherapy, and PET CT, of course, has a wide variety of uses once the diagnosis is established. So first, when you see a imaging or a CT scan, when should you think of a malignant mesothelioma, or when should your antenna go up when you see a pleural thickening? So typically, the pleural thickening that shows some different imaging features that may suggest malignancy that we are going to discuss now. So typically, the malignant pleural thickening will be nodular. So of course, the benign may also show nodularity, but typically a more than a centimeter size of pleural thickening with nodularity is when you should be suspicious of a malignant disease like mesothelioma. And typically, if you see the benign pleural thickening, typically involves the costal pleura, and then asbestos-related plaques even involves the diaphragmatic pleura. But typical involvement of a circumferential pleural thickening with thick nodular enhancement more than a centimeter in size, and typical involvement of the mediastinal pleura also should really alert us to think of a mesothelioma rather than a benign pleural thickening. So let's see this with example. So if you see, this is a enhancing pleural thickening on the left. You see some fluid also effusion. But see this is just about maybe a centimeter size, but there is no nodularity. And plus you can see, appreciate the changes of chronicity. That's a contracture of the hemithorax, volume loss. That suggests that it has been around for a long time. And you might even see calcification along with also the volume loss signs and other sign of fibrothorax that is present in this case as well. So these are the typical presentation of a benign pleural thickening. As against this, the malignant pleural thickening will look something like this. So this you can, if you can appreciate that this is much more nodular and showing a heterogeneous enhancement, clearly more than a centimeter in size, and also appreciate how it is circumferential rather than this costal and diaphragmatic involvement. And also the mediastinal pleura is typically involved. So this is how the malignant pleural thickening can be distinguished from a benign pleural thickening. And this is what I meant by frozen mediastinum spine, specifically useful with radiographs also. So it typically means is that though you have a mass pleural thickening and you have a pleural effusion, in mesothelioma, you don't see the typical mediastinal shift or the mass effect. The reason being there is a pleural thickening, but there is a restricted underlying lung expansion, and there may be possible mediastinal infiltration also not allowing it to shift to the opposite side. So there's, if you can see in all these examples, these are all three cases of mesothelioma. You can appreciate that there appears to be a pleural effusion or pleural thickening, but there is no mediastinal shift in any of the cases. So that is where the time, again, on radiographs particularly, you can think of a malignant mesothelioma. So let's see some cases. So this was a typical case of a mesothelioma. You can appreciate again, there is a diffuse nodular enhancing pleural thickening that is circumferential involving the mediastinal pleura as well. There may or may not be the mediastinal invasion, and all those signs also we are going to see, and specifically how the MRI is going to be helpful in that. You have some pleural effusion also, and again this coronal and sagittal reconstructions really help to pick this fissural involvement, which is also very, very common in mesothelioma, and that's how we make the diagnosis. One more example, you can see that there is a similar nodular enhancing pleural thickening on the right side. It is more than a centimeter in size. Mediastinal pleura involvement is also present, and we did the biopsy and the diagnosis was proven. So that's how the typical case of mesothelioma looks like on a CT scan. But then coming to the important question, that when should you think of pleural mesothelioma and metastasis? So by and large, the biopsy will be required, and that's how the diagnosis is made. But in general, the important features that really helps is the mesothelioma will be typically unilateral, while metastasis may or may not be bilateral. So the rule other way around doesn't work, but if you have a bilateral disease, you are going to think of metastasis first. Then you have a fissural involvement that is very, very common in mesothelioma as compared to the metastasis. And you as we discuss about the frozen mediastinal sign, you can see contracture of the hemithorax rather than the contralateral shift that is seen with metastasis. And then because typically most of the patient with mesothelioma have some other asbestos plaque related disease, so you will see those calcified pleural plaques and other sign. And in lung metastasis may be present. And of course, when you have a known primary that is present elsewhere in the body, the first thing then you will be thinking of a pleural thickening as a metastasis disease. So that was about the typical presentation on CT scan. But what is the role of a PET CT scan? So it can really help sometimes to differentiate the benign from the malignant pleural thickening. So at times, even the CT scan appearance is not very typical. The pleural thickening can be benign or malignant. And in those cases, the PET CT can really be helpful by picking up the FDG uptake and showing the activity. And more so important in nodal metastasis. So on CT scan, we rely on the size criteria. So the sub-centimeter size lymph nodes are difficult to comment on CT scan unless they show some other morphological feature like necrosis, etc. It is difficult to comment on disease spread in case of CT scan. While in PET CT, you can pick up the activity even in the sub-centimeter size lymph nodes. So the mapping of the disease curve will become really easy once the diagnosis is established, because it's a whole body scan. It's sometimes even the guidance for biopsy can be important with PET CT, that it allows us to pick up those active areas that you can use to target the biopsy, especially in a heterogeneous or a necrotic disease, to avoid any false negative biopsies. And of course, in response assessment. So this is how the typical PET CT looks like. Again, the similar findings of diffuse pleural thickening, nodular enhancing, and you can see how the FDG uptake is very easily appreciable in case of PET CT scan. And even this fissural nodules or the fissural involvement, and you can see even those also show FDG uptake. So that's how the PET CT can really be useful in diagnosis, guidance to biopsy, and even in response assessment. And finally, the role of MRI. So role of MRI is actually limited, and by and large, we will not be doing MRI unless it can be only used as a problem solving tool. So sometimes the chest wall or a mediastinal endothoracic fascia involvement that might upstage the disease or decide the surgical management. If the question is really important and it is difficult to answer on CT scan, then MRI can be really, really useful. Especially the diffusion imaging is also now coming big time for the response assessment as well, which is otherwise also typically done with dynamic perfusion studies. And even the dynamic perfusion helps for the pre-treatment to decide which tumor are more likely to respond to chemotherapy, because the high pre-treatment median efflux rate are more likely to respond to the chemotherapy. So an MRI, otherwise disease typical looks like this. The T1 signal is almost iso-intense or a mildly hyperintense as compared to muscle. T2 is heterogeneous signal intensity, but you will see some hyperintense areas and will show a avid post-contrast enhancement. But this is how it shows the chest wall and the mediastinal invasion so well. So while this can be sometimes difficult to pick up on CT scan or even with PET CT scan, MRI will show this beautifully, especially the post-contrast imaging, the chest wall involvement as well as the mediastinal invasion. And also you can see in this example, there is a fissural involvement, but the diaphragmatic involvement was really difficult to comment on CT scan, while on MRI, it becomes really easy to say that this was involving the diaphragm as well. So that's the importance of MRI, typically used as a problem solving tool. And then this was all about the diagnosis and how to stage the disease and about the response to treatment. So of course, whenever there is a chemotherapy is given and to response assessment of response is decided, PET CT typically was the imaging modality of choice. But if you have doing just a CT scan, of course, you are relying more on the morphological response. So you can clearly see here clearly the disease burden has regressed, the size has come down significantly. So that's how the CT response is assessed. On PET CT, in addition to the size or the morphological response, you can comment on the metabolic response as well. So whether the residual thickening is still metabolically active or not, only a PET CT can tell. So as you can see, there is a good partial response, but still there is FDG uptake suggested there is a residual disease present in this case. And even so, more important to pick up small recurrences. So this patient, if you can see, there is a pneumonectomy done. And in post-op imaging on CT scan, there were lots of soft tissue thickening, but it was difficult to comment and differentiate from the post-operative changes. So again, the PET CT will really easily show this FDG uptake wherever there is a areas of recurrence. And that's how it can be really useful in case of post-operative status also. And finally, for MRI, again, in response, just like in diagnosis or staging, it comes as a problem-solving tool. Similarly, in response assessment also, especially because of the diffusion-weighted imaging and the perfusion imaging, it can really become easy to pick at times. And there are lots and lots of new articles that are coming that are exploring the use of diffusion-weighted imaging, though we have also not yet explored it completely, but this how it has been a promising tool that the article describes that the post-treatment, if the rise in ADC value is easily much more appreciated, then it suggests the response to treatment. And same way, the perfusion imaging can also be really helpful. So the images on your left are pre-treatment, while imaging on the right are post-treatment. And you can see, apart from the morphological response, there is a significant drop in the KEP value or the perfusion of the tumor also that's suggestive of a response to treatment. One more example where you can see on pre-treatment, there was a diffuse disease, and with post-treatment, the disease has gone significantly down. And more so importantly, the perfusion values have also gone down significantly. So to summarize over, I think just about in 10 minutes, what we have tried to understand is the various importance of the radiological modalities like CT scan, PET CT, and MRI for the diagnosis of mesothelioma. And we understood how we'll differentiate the benign from the malignant disease. When should your antenna go up and you should be suspecting a malignant disease? There are certain signs that may suggest metastasis versus mesothelioma, but typically we will end up doing a biopsy to confirm the diagnosis. MRI can be really important problem-solving tool, both in the diagnosis, especially for staging, mediastinal invasion, diaphragmatic invasion, etc., and even to response to treatment with perfusion and diffusion-weighted imaging. And PET CT is, of course, really helpful for the mapping the disease in the body, guidance for the biopsy, as well as the response to treatment. So with that, I will conclude my talk. Thank you so much for your attention.